Welcome to In the ED Now, a podcast that makes you an excellent physical therapist in the emergency department. I'm your host, Dr. Rebekah Griffith, and I'm really happy today to be joined by John VanEyk. Good morning.
Good morning. How are you?
Well, I'm well. How are you?
Doing well at 6 o'clock in the morning.
I know, I think it's funny. Really, you can record a podcast anytime, right? But when you're a practicing clinician, sometimes it has to be at 6 o'clock in the morning.
Yep.
So tell me a little bit about yourself and what you do, because you're a long-standing ED and you work in a kind of an unusual setting.
Yeah, I'm a physical therapist. Obviously, I work in the ED now, fully embedded, but it wasn't always that way. I work for the uh, Seattle Medical Center, which is a 638 center, and it's meaning that it is a tribally run. The tribe runs the hospital within the Indian Health Service. And so I've worked for the Seattle Medical Center for about 16 years. I did 10 years the first time and was just kind of as needed. And then by the time I left, I was a hybrid. I would spend some time in the ER and then ED and then the rest of the time in the clinic. And then I left. And then in 2020, they asked me to come back, or we came back in 2020, and it was in the height of COVID, so it took me a little bit to get into the ER. That's what they asked me to come back specifically to do, is to restart the program. And I was about probably a half a year to a year delayed getting in, and then I was a hybrid again. Spent half my time in the ER, half in the clinic, and then I became fully embedded in 2024, I believe, and I've been there ever since.
Well, so I think that's a really good thing to talk about is the fact that you have experience with three different models, right? So you've done the on-call model, you've done the hybrid model, and you've done the embedded model. So can you talk a little bit about sort of the pros and cons of each one of those and what your experience was?
Sure. The come down as you need is how I started. And I think that's a great way to start, just to get your foot in the door, kind of show people what you can do. And it also gives you a chance to say, do I like this or not? And so I was one of those ones that like, oh my goodness, I love this. And so, but the problem is that, you're going between patients. You're going when there's a cancellation or a no-show, and so your time is limited, and you never know how much time you're going to have to spend in the ED once you see a patient. And so, it has some stresses that way, and sometimes you can't provide the amount of care you want, but I do think it's a great way to start. The hybrid model is nice. What I did was I saw my patients uh, in the clinic after I saw them in the ED. And so that was nice. There's follow through. And I think in native cultures, there's this thing called kinship. In the Navajo culture, it's called ke. And so, there's that relationship established with the patient, kinship relationship. And so to them, it is important. Like, hey, you saw me in the ED, you helped me feel better. Now I get to see you in the clinic. And so that was nice. And so there's just good follow through. You knew the patient, you kind of knew what they needed, and the show rates were good. When I was
Yeah.
doing that, we had about an 80% show rate, which is pretty good, especially in Indian country where rides are limited and weather can limit access to roads and so on. So that was actually a really good show rate. But I think, again, if you really enjoy the ER, you desire to be there the whole time. And so everybody asked me how I got fully embedded in the ED, and I said, you take your boss to one of Rebekah's courses. And so that's what I did. And within about 2 to 3 weeks after going to your course in Utah, I was fully embedded, and that has been great. We did find something interesting. Our show rates for patients I referred to the ED and set an appointment up for. That's the key part, is I set the appointment up for them. Dropped from 80% to 20%. And so that's probably a whole nother discussion sometime of maybe why that is. But, I think it did something important. We started having the patients call to set their appointments, and those patients who call show up at least 80% of the time, if not greater. So there is that benefit. I also think it gives the patient a little more feeling of autonomy and making the decision whether PT is for them. I think sometimes we tell patients what we think they should do instead of really just letting them decide. And I've really enjoyed it. I've been, like I said, since I think November 2024, I believe. And since then we've grown. I've got another PT. He's a former EMT. He's Navajo, which is great. He works with me on Mondays now. And then we have Fridays covered. That's my day off. So we've been growing it. I actually have a PTA that works with me, and he's working with me more, which really is just. I mean, that has changed. My goodness, that has changed the treatment game in the ED so much, because if I have 4 patients waiting, I can eval. He comes in, I give him the treatment I want done. He does the treatment, of what I don't want to do or can't do, and I move on to the next patient. And so it's highly efficient. He likes it because I do the documentation. He co-signs a note, and it's billable. So it's like the best of all worlds. But it allows me to see more patients, and we're able to move them through more quickly. A couple of weeks back, we had 4 patients roomed about the same time, and we were able to finish all 4 patients in an hour and give them high quality physical therapy. And
That's
that's
great.
because he followed. I would see them for the eval, a short treatment. He would finish it, and we moved through, and the ED was impressed as well.
Well, I love that. And so, a couple of things that you said that I want to touch on is you said that the no-show rate was about 80% when you were scheduling patients for their own appointments. Is that right?
Yes, that's after I left
Right.
the
So you didn't
yeah.
have that follow through. But I want you to know, and for everyone who's listening, the 80% no-show rate from an ED visit to a follow-up appointment is really common. So
Mhm.
that's definitely not unique to your setting. It's super common situation. So it is usually what I do tell people to do is have the patient schedule that appointment themselves because
Yep.
that's the patient that's more likely to follow through than patients where the appointments are made for them. However, that's not always the case because you are going to have some patients that don't have the health literacy to make the appointment.
Mhm.
They don't speak the language. There might be a ride barrier. There might be difficulty accessing the right PT specialist if that's the issue that they need there. So I love that. Not an unusual situation, but a really good strategy for solving that. And then you are one of the only PTs I know that works with a PTA in the ED because a lot of people think, well, we only eval here, but we're evaluating and treating. So
Mhm.
I just want to hear more about like how you're passing that off and knowing that the patient's going to get the care they need when you haven't really had an opportunity to assess how they did with the initial treatment.
Sure, that's a really great question. It's ideal if the PTA can be in the room with me. That's really great when I'm doing, starting the eval, but that's usually just the first patient, unfortunately. And and so then, he tries to come in as fast as possible,
Mm.
to, um, you know, to so he can actually be there and kind of understand what's happening with the patient. And he usually is able to do that. And so, he's kind of then able to see what my goal is, what the patient's needs are. And usually for like manual therapy, I've done them in depth. If it's dry needling, I've done the dry needling and so on. And so he's there to basically do the HEP that I have already printed off to give the patient, and then also apply any like DME, so crutch training, cane
Hmm.
training, bedside commode, whatever. And that's been really nice because that's just really simple. But I've also been teaching my taping technique. So if I'm really busy, he's able to tape that patient for me, and I'm with high confidence. And then usually I come back in and check the patient, make sure there's no other needs, or he gets me usually. And so it just really works. It's pretty fluid actually, and I think the ED lends itself to that because you're moving in and out of the room all the time anyway. And where I think in the clinic sometimes it's harder to get that nice flow, because the patients, this is my time. Where the ED, they know what life is like in the ED. It's usually hurry up and wait. Although our ED does a really good job of moving patients through. But yeah, it just works really well. I love it, and he's a really skilled, PTA, and he's got a sports background, and so sometimes, he catches things that I've missed, and we just have a really great working relationship, and so I think that's really nice too.
I love that. So, talk a little bit more about how your setting is unique. I know, having been there with you and worked alongside you for a couple of days, was really cool for me to see just the community, the differences and things that you have to ask the patients, the difference in sort of the cultural standards that are expected. So if you could just share some about your unique setting, that'd be great.
Yeah. Again, I'm on the Navajo Nation. We're in the, near the capital. So we're in Fort Defiance, but 5 miles down the road is Window Rock, which is the capital of the Navajo Nation. So I always joke to say we're a suburb of Window Rock. Rebekah's been here, so she'll chuckle at that. We're very, very rural. So,
But just so
but
people have some concept of where that is, it's sort of
yeah,
like
yeah,
in Arizona, but sort of right over the New Mexico border. Like I ordered a
correct.
pizza in Arizona, I picked it up in New Mexico kind of situation, but really all of that's the Navajo Nation, which is technically a foreign country, right?
Correct. Yeah, it is. People don't realize that. It's considered sovereign land, and so you are on the Navajo Nation, and so we are like right on. The Navajo Nation is made up of 3 states. It's Utah, Colorado. I'm sorry, not Colorado. Utah, New Mexico, and Arizona. Part of the Navajo Nation originally was in Colorado. That's why I said that, but it's that's not anymore. But we're right on the New Mexico border. So our outpatient physical therapy department is actually in New Mexico. When I walk out my back door, I literally walk into New Mexico. So we just don't have the state line borders like, Arizona and say California would. A lot of times you don't know when you're going into New Mexico and when you're going back into Arizona. But it's the largest Native American reservation in the country. We're actually bigger than 12 states, not 12 states combined, but there's 12 other states that we're bigger than. And I forget how many. I think it's 52 million square. No, that's not right. It's huge. I think it's like 25. I should have gotten that fact for you. I'm sorry. It's
That's
large,
okay. It's
but
big.
yeah, it's big. I mean, it's you. If you're driving to Albuquerque, a good portion of that trip on I-40 is right next to the reservation, and we serve in RED about 40,000 people a year, and it's public health. The treaties guaranteed Native Americans to health care, and so the Indian Health Service was established. I started out with the Indian Health Service at Fort Defiance. And then because of the 638 Self Determination Act, tribes can actually run their own hospitals amongst in their own EMS, their own fire departments, their own police departments, but hospital is one of them. And and we've been, I think now, I believe it's 15 years, I believe, 638 hospital. Actually, it's 16 years. And it's run very well. And the nice thing is that we are able to give equipment. I know in
Mhm.
your courses you talked about maybe trying to have a donated equipment supply closet somewhere, and we were able to give equipment. So if a patient comes in and said, "Hey, I don't have running water, I've got an outhouse," and you don't want them walking out to the outhouse at night, we can give them a bedside commode. We can give them braces. We can give them a shower chair or a tub transfer bench. And so most of our patients leave the ED fairly safe. Does it guarantee they won't fall at home? No, but it significantly reduces that risk. So
Yeah.
it's very
The
satisfying.
The barriers, though, so I feel like
Mhm.
one of my barriers, right, is that it is hard to sometimes get equipment for people based on their insurance, based on what vendor they can use, like all of that
Yeah.
nonsense. But on the other hand, I can get a home health care set up for almost any patient, even in rural
Right.
areas of Colorado. And I can send patients to subacute or acute rehab
Mhm.
facilities if I need to because they're not safe to go home and they have extensive rehab goals. But talk about what do you do? Because that's not an option for you.
That's a huge obstacle across our reservation, especially. New Mexico has some home health, so occasionally we have like this great moment where we can make it happen. But usually that person's out of our service unit, so they're up towards Farmington or whatever, come to our ED. But yeah, we have to work with. Sometimes we work with public health nursing to go out to the home, but we then usually have to work with the patient. What we call purchase referred care, which is the kind of our hospitals kind of managed care people. They're the ones that help get the insurance approval or get the hospital to actually pay for those treatments or whatever the patient needs if they don't have insurance. So we have to work with PRC, and they often will try and get safe rides set up so that we can actually get them to the clinic to be seen, because there's no other options. And sometimes it feels pretty helpless because there are no other options. We're
Yeah.
trying to get a program going where we can do some in-home visits ourselves, not the ED staff, but some of the other therapists, trying to think outside the box a little bit. We've made a couple attempts due to like just weird events. We've yet to make it happen. We're still hopeful that we're going to be able to eventually be able to see some of these folks who keep falling, for example, and really do need a home safety assessment to be able to see them in their home.
John, a lot of people say to me that they don't think that they can make a sustainable EDPT practice in rural areas. So what would you tell those people? I love that
Um,
face.
yeah, yeah. No, I actually think that you can. I think actually in some ways, there's no better place to establish a PT presence. I think that hospitals also need to start thinking outside the box. I think that the major obstacle is usually the rehab department. And they're like, look, it's hard enough to recruit our own therapists. We don't have enough therapists ourselves. There's no way we're going to let you go to the ED. And so I think that ED departments need to start thinking out of the box and saying, well, then we're going to ask for the position ourselves, and they're going to be our employee and work from that approach, because it just makes so much sense. Most rural clinics are understaffed. And the truth is, right now, a lot of people don't want to work in the traditional outpatient setting because of, the history of having to see 5 patients at a time. But there is interest in primary care access, as a PT and ED PTs. So I think it's a huge field that's open to actually, if you were to actually advertise for and say, hey, we want to be able to capture our patients as they come in acutely, so they don't become chronic, so they don't, sit on a wait list for 3 months waiting to get into a rural clinic because there's not enough PTs, and then have to be seen with 5 other patients because that's the way they do it. I think it's a great opportunity to actually give really high quality, top of scope care in the rural setting. And I think there's just no better place for it.
Yeah, so there's this ongoing debate in physical therapy about whether patients should be or PTs should be specialists or generalists. And
Mm-hmm.
one of my favorite quotes is, "A jack of all trades is a master of none, but oftentimes better than a master of one." So, what's your sense of what type of physical therapist you need to be in the Indian Health Service or in the Navajo Reservation, whether you're in outpatient, whether you're in inpatient, or whether you're in the ED?
Yeah, I mean, I think I have worked with people on the Navajo Nation. I've worked with some of the best clinicians I've ever worked with, to be honest.
Hmm.
There is this and that goes for doctors, nurses, PTs, OTs. There is this kind of like draw to the res, partly because of the land, the people, which are all beautiful. But I also think there's this draw because people are tired of the private sector and the games you have to play with insurance and the games you have to play with hospitals.
Hmm.
And so you really get some people here who are really skilled. There's been ones who are just like skilled in manual therapy, and those are great. But I think the best clinicians are your generalists. I mean, because you are seeing birth to elderly, to the geriatric population, and you're seeing sports injuries. You're seeing a lot of ortho injuries. You're seeing a lot of chronic pain. And so being able to be a generalist and be able to come in and see these patients makes it so much easier. And I think it makes it so that you're a little more flexible in your approach, and you can walk in and comfortably see any patient. Where if I'm just a manual
Yes.
therapist, I may come in and there's a kid sitting there and like, I can't see that kid. I'm not a pediatric therapist. But in the ED, we see them from birth to geriatric all the time, and it's great.
Hmm.
It makes it interesting. It keeps it exciting and fun.
So that being said, do you think that new grads can practice in this setting, both kind of on the Navajo Nation or in the ED or both? Like, what are your thoughts about that as a PT with over 30
Yeah.
years of experience?
Yeah, I'm glad you asked me that, because I think there was a time where I would have said, oh, it's got to be, somebody with at least 2 years experience. And having taken students in the ED, and I've had a lot of students in the ED, and I'm going to be getting another one here in July. I'm very excited about that.
Oh,
Um,
good.
and just seeing how quickly they adapt and how excited they become, I'm like really like realizing like, okay, we're getting a captive audience. We're getting a true believer right before they even become a PT. So yes, I'll take students, but I love the new grad because they don't have any, they're not cynical yet. And that's
Yeah.
important. They don't have like, this type of therapist yet. So you're getting them right away in the mindset as I'm a generalist, and I'm going to be, the best I can be at seeing all these patients. And you have less egos sometimes more egos. It just depends, but usually it's less. And I just think I think they're just more open to new things in the excitement of the ED, where I've taken somebody who's got 10 years of experience. They walk into the ED, yeah, I want to go into the ED, and they spend one afternoon in the ED with me. I'm like, yeah, I never want to do that again, because it's outside their comfort zone, because they need structure, and that's okay. But I think that you can teach almost every therapist not to need that structure and to be able to, work with some flexibility and some open-mindedness, and realizing that each patient is different. So we should be able to treat each patient different.
Yeah, there's been kind of a big debate on social media over the last
Mm-hmm.
week where there's clear difference between PTs who practice in the emergency department and PTs who are being forced to pick up patients in
Oh
the emergency
yes.
department.
Mm-hmm.
And I think there's a practice difference. I think there's an attitude difference, and I think there's just a goal difference as well, right?
Oh yeah, no, I think that's absolutely right. I do say if you're going to doom a program if you force somebody in there, and for myself, like I like to try and get every every employee we have to come and spend time with me in the ED. That's how we started getting PTAs in there. They wanted to see what we did. I'm like, yeah, come on down. If you got a patient that's canceled, come on down. But what I have found is that, and what I've learned rather, is that if somebody comes in and is just not comfortable with it, I'm not going to force them to, because I want them to enjoy. I do what I love, and I absolutely love the ED. And but I don't want to be told to do something I don't enjoy, and I think that's important with everybody you work with. And the success of a program and the ability to be able to work with other clinicians, the docs, the PAs, the nurse practitioners, the nurses, is really dependent on somebody who loves what they do. Because if you don't love what you do, you're not going to seek those patients, you're not going to engage, and you're going to do in the program, to be honest.
Yep.
And so, yeah, I'm a big believer in finding those people who love it. And actually, I would say 90% of the people I brought into the ED actually really love it, though. So that's really a cool thing.
Yeah. I love the autonomy. I love the top of scope
Mm-hmm.
practice. I love the connections with the physicians. But I think, I mean, and I totally get it. Like, if you are an ICU therapist and you love that, you don't want to be pulled down to the ED. If
Mm-mm.
you're a rehab
Yeah,
therapist, it's just not for everybody. So I appreciate that. The last thing that I want to ask you about, which I think is unique, you're one of the only people that I know that does this, is musculoskeletal point of care ultrasound in the emergency
yes.
department. I think it makes so much sense. And if I had unlimited time, I would absolutely go and learn how to do that. So, talk people through what that is, how you got trained to do that, and how it's enhanced your practice.
Sure. So last July, so July 2025, I went to a course in Florida. It was just where it was, by Stephen Ramsey. And he is an ICU nurse at Emory in Georgia. Brilliant guy. Started doing point of care ultrasound in the ICU because of checking for lung slides and cardiac function and so on, and then just kind of got into it and learned musculoskeletal. And so I went. It's a great introductory course, by the way. I'm not here to promote him. I'm not getting paid. He's just a brilliant guy, and I think it's a great course if you want to just learn what it is. And he told me this at the course: go home and practice and watch YouTube videos, and that's how he taught himself. And so I went to the course, got comfortable with the using the machines, the ultrasound machines, and came back. And day one after the course, it's rare that you get to do this. Day one, got to do a knee, and then I got to do a shoulder. So I think I did 2 or 3 that first day back. And lo and behold, it's like, wow, this is pretty amazing. I'm seeing stuff. And since I use it almost every day, in the emergency department. And I can look at ankles, I can look at wrists, I can look at knees and shoulders, look for foreign bodies. We just have a new physician started. She's fellowship trained with ultrasound. And so she's really revolutionizing what I'm doing as well, because before we were just saving the images. Now I can add the patient information in, put her as the responsible MD for my treatment, and then she reviews it. And so that's changing it. It's making it more official, which is really important, to be able to make it part of the medical record instead of, some saved images somewhere and then a report. Every eval I do has a report in it that I have to write. So I feel for the radiologist now, but I
Yeah.
love it. I have found a DVT that was no one thought it was there. We weren't even looking. In my course, I learned that you always check the neurovascular bundle while you're at the knee. Always check for a DVT, just because, it's mainly because DVTs are over diagnosed without ultrasound confirmation. And there's some really good studies out there about this. Most of them are Baker cysts. So, I'm always looking for the Baker cyst, but I always slide over, and lo and behold, we had a DVT. It was a pretty big sized one. And so, but I have found tendon tears, fractures, tons of effusion. It's just a really handy tool. In the rural setting, it is even more handy because you don't have access necessarily immediately to an MRI.
Right.
And you can look at something and go, okay, I don't think there's a supraspinatus tear here. But actually, with supraspinatus tear, we know now that ultrasound is basically as reliable as an MRI when it comes to diagnosing a supraspinatus tear. They're great to see if the biceps, long-headed biceps tendon is still there. We found a couple ruptures that way. And so it's really a handy tool. It's quick. If you read most ultrasound literature, say it's painless, but I would think my patients disagree, because you're pushing over the area of pain. You're taught to use the probe to find that area of pain, and then correlate the findings to the pain. And so, but it's just quick. Now that am able to enter into the EHR, it takes a little longer, because now you are having to label the pictures and put the patient information in, but it's still well worth it. And the evals, when you write them up, are a little longer, because you're having to report on your findings. And so if you look at every compartment of the knee, it's a fairly lengthy report.
Well, I think that's wonderful, and I hope to see more physical therapists doing that going forward. One of the last things I want to ask you about, well, and maybe we could just use it as a great example, is I talk about how physical therapists in the emergency department lead to decreased hospital admissions, decreased unnecessary imaging, decreased bounce back to the ED, and an overall increase in throughput time and cost savings. But the example in your setting that just stays with me the most were the number of patients that were literally being helicoptered out of your
Mm-hmm.
community with vertigo. Can you just speak to how you revolutionize that process? And if you just think about like one less helicopter per year, you've probably paid for two PTs.
Yeah, I mean, we've been really instrumental in helping to rule out stroke, and coming and going, look, this is a hypofunction, this is BPPV, this is labyrinthitis, or this is an old head injury, and so we've got kind of this mixed package. And so it gives some confidence to be able to not have to like call the bird in, to speak. And yeah, depending where they're going, that can cost between $30,000 and $50,000. And we usually save 3 or 4 or 5 times a year. Um, and it's not just vertigo. I mean, there have been several times where we've had cervical spine fractures, and we're able to, say, wait, don't send them out. It's stable. Let me make some calls and get an orthotist over here. And we work with a great orthotist from Gallup, and he's come over to the hospital and fit, braces that the neurologist at UNM or at Flagstaff wants them in a specific brace that we can't carry and could not put on. And so that saves tremendous amount of money. So we do. And then on the other hand, it's funny because I keep this tally in my head, up here of like saved a trip, saved a trip. But then we have found the Cata equinas that need to go.
Right.
And so now it just costs them a trip. But I'm always happy
But
at the end of the year. Go
the
ahead. I'm
key is
sorry.
unnecessary. We're reducing
Yes, yes, yeah.
unnecessary things,
Mhm.
but oftentimes we're also finding necessary
Yes,
things.
yeah. But my goal at the end of the year is that my saves exceed my hey, yeah, fly them out. So if I can come out ahead and send to save 5, then I'm always like, yeah,
All right,
yeah.
John. So, parting thought, I always ask people to give their top of scope tip, and that can be anything about being a physical therapist, it can be about the emergency department, it can be about life in general. So, what's your John VanEyk top of scope tip?
Okay, it goes back to diagnostic ultrasound. I think it's the future of our profession. I think in the ED, it's even more unique because the doctors are coming to you and sometimes actually having you see patients that they normally wouldn't have you see because they value your expertise on the ultrasound. And I just think it opens up a new door that allows us to diagnose more quickly, diagnose more accurately, get us to be able to work with radiologists closer, doctors closer, and just really add a value to what we do. And I do think it's the future of not just ED PTs, but PT in general. And we've got to get on this bandwagon, or however you want to say it, because chiropractors are getting they're seeing the importance of it and they're jumping on it. And so we need to be there. We need to be able to do this, and it just allows you to practice at a higher level, and it gives a higher level of respect too. That I feel like we're well respected as a profession, especially when we work in the ED, but it's even more. And I have so much respect for uh, our doctor who's fellowship trained. But the other day I asked her a question. She's like, John, why are you asking me? You're better at musculoskeletal ultrasound than I am. And that was like the hugest compliment because she is freaking phenomenal. And I love her to death. And she's just so much fun to work with. And so, yeah, I think that's my tip. And just always strive to be at the top of your scope. I will say that you have to make it a mindset and everything you
Mindset
do.
plus skill set.
Yeah, exactly. Because I think sometimes in PT, we excuse our way out of what we can do.
Oh, yeah.
And and I think it's a mistake. I think that when we say, "Oh, I got to send that referral back because I didn't like the way the doctor wrote it," I'm like, "Oh my goodness, what are you doing?" Because you just made us a subordinate, not a top of scope person. And I can give example after example of that. And but I think you just hit something. I have heard this be used before, where we'll talk about top of scope, but forget that it's got to be your skill set attached to it. I do think that having the mindset of top of scope makes you want to constantly improve your skill set, though. And
100%.
I think that's one of the biggest things that life changers in my life is after I heard your first, after I went to your first meeting, your first conference, I and got introduced to this top of scope thing. It just really changed the way I viewed myself as a clinician and what I should be striving for and what excuses I should stop making. And it just really changed my life. And so I probably talk about it too much and drive everybody crazy, but it's my soapbox now. So good
I
job
gotta get
for
you a t-shirt, John.
I know.
I'm wearing
I
it. I'm
still don't
wearing
have a
the shirt.
t-shirt
Top of
shirt.
scope, mindset
Yeah.
plus skill set.
Yeah, yeah.
All right, so for everybody listening, if you want to hear more from John, you can register for our Top of Scope Summit replay from 2025. He gave a really great presentation on musculoskeletal ultrasound, along with a number of other great clinicians. So that is available for registration. In addition, we had one the year before that was 1 day of patient management, 1 day of practice management. So that's available for you on demand. If you are interested in starting an EDPT practice, please feel free to check out the book, Top of Scope, the Emergency Department Physical Therapist Handbook. And with that, you've been in the ED now and you're officially discharged.
Well, thank you. Appreciate your time.
Thank you.